Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of the McTox Curriculum, built for residents and fellows from PGY 1 to 5. This topic is about heavy metals. This presentation is brought to you by Wahid Al-Hazani. By the end of this 10-minute talk, you will be able to 1. Recognize lead and mercury toxicity. 2. Discuss lead and mercury workup and management. And lastly, 3. Identify lead and mercury antidotes. Case 1. An 18-year-old male with known moderate cerebral palsy and mental retardation presents with a change in behavior and difficulty breathing. He looks unwell, mildly agitated beyond his usual baseline, and he's using his accessory respiratory muscles. Vitals demonstrate a heart rate of 116, a blood pressure of 130/79, a respiratory rate of 24. He is saturating at 92% on room air. His temperature is 36.8 degrees Celsius. Thinking about this case, what other elements upon history and examination would you like to obtain? The patient's mother stated that this morning he broke into an old thermometer. She also reports that he has not been himself for a few days and seems to be in pain holding his stomach. He had a history of ingesting unusual materials in the past, but the mother insists that he did not ingest what spilled from the broken thermometer because she witnessed the event and vacuumed up the contents of the thermometer immediately. Upon examination, you notice mild wheezing with generalized abdominal tenderness without guarding. His mother denied any history of bronchial asthma. What is your diagnosis so far? Thinking about the differential, what kind of workup would you perform at this time? Your toxicology blood work reveals the following results. You note a mild elevation of AST with anemia and non-specific leukocytosis with mild CO2 retention despite tachypnea. You also notice that ethanol, aspirin, and acetaminophen levels are all normal. Of interest, further workup of the patient revealed that he had pulmonary exposure to elemental mercury in addition to ingestion of lead from old paint chips. Let's digress for a moment from the case and discuss mercury. Mercury exists in 3 forms: organic, inorganic, and elemental. Ingestion of organic methylmercury compounds causes delayed neurologic symptoms due to its lipophilic qualities and slow elimination. Remember, such substances easily cross the blood-brain barrier. Alternatively, ingestion of inorganic mercury salts results in GI and renal toxicity. Inhalation of elemental mercury, which is volatile at room temperature, results in pulmonary toxicity and acute respiratory distress syndrome acutely, in addition to central nervous system toxicity with chronic inhalation. Now, it is important to note that elemental mercury is poorly absorbed from the GI tract. Confirming the diagnosis of mercury exposure depends on the type of mercury involved. Whole blood RBC levels is useful for organic mercury. Urine and blood levels can be used for inorganic and elemental salts. It should be noted that mercury levels do not correlate with severity of toxicity. Treatment of mercury exposure starts with appropriate decontamination. Chelation can be done by oral DMSA for organic mercury, intramuscular dimercaprol, also known as BAL, or intravenous unithiol, also known as DMPS, or oral DSMA can be used for inorganic mercury. Elemental mercury can be chelated using DMSA or unithiol. Now let's turn our attention to lead toxicity. The clinical picture of lead toxicity is nonspecific and depends on route, dose, and chronicity of exposure. For example, acute inhalation of large amounts of lead fumes causes acute non-cardiogenic pulmonary edema. A lesser exposure, which is still chronic in nature, causes other systemic manifestations. Ingestion of lead may result in abdominal pain, anemia, agitation, ataxia, and in the long run, peripheral neuropathy. Often elevated renal function tests and liver enzymes are also seen. Furthermore, X-ray may reveal radiopaque material in the stomach. The decontamination method of choice for lead ingestion is whole bowel irrigation. Of note, whole blood lead levels correlate clinically better with chronic exposure compared to acute ingestion. Another way to detect lead exposure is to measure erythrocyte protoporphyrin concentration. Management is mainly supportive. In severe lead toxicity, especially in the presence of encephalopathy, intravenous treatment is indicated with BAL or EDTA. However, in more subtle cases, an oral succimer might be sufficient. Let's talk briefly about chelating agents. Dimercaprol, or BAL, is an oily liquid containing peanut oil and is used for lead, arsenic, and inorganic mercury exposure. It is given intramuscularly. Succimer, or DMSA, is a water-soluble analog of dimercaprol. It is given in an oral form. It is only used in lead and arsenic exposure. Unithiol, or DMPS, is another water-soluble analog for dimercaprol. It is used to treat lead, arsenic, and mercury toxicity. This agent is usually given either orally, intramuscularly, or intravenously. EDTA is given intravenously, and in rare cases intramuscularly, to treat lead encephalopathy. This is the end of this presentation on heavy metals. Please ponder the following questions. 1. Is there a role for hemodialysis in lead toxicity? 2. What type of anemia does a patient with lead toxicity typically present with?